So now the most high yield topic, very much tested, is cystic fibrosis. Cystic fibrosis. Let me tell you this whole disease in a single story. We have chromosome number 7. On the chromosome 7, we have the cystic fibrosis transmembranous protein regulator, conductance regulator gene. This gene encodes chloride channel, and this chloride channel goes to different three different areas and perform transport of the ions. So if this gene has a mutation, has a frame shift deletion of the phenylalanine 3 nucleotide deletion at the position of 508, then this deletion can causes the misfolding of protein, which is going to be the cell membrane receptor. This misfolded protein doesn't go to the reticular rough endoplasmic reticulum, to the Golgi apparatus and to the cell membrane. Rather, it get retained in the rough endoplasmic reticulum, and then it is shunted to proteasome for protein degradation in order to get amino acid, and again try to make this protein, and again there is a misfolding. So this whole vicious cycle is get started. So in this way, the whole intercellular protein trafficking is impaired. Protein traffic is impaired. So there is no chloride channel, which is an ATP gated chloride channel on the lungs epithelium and GIT epithelium and on the sweat gland. So whenever there is no chloride channel on the respiratory and the enterocyte epithelia, then there is no secretion of chloride with water. And in the sweat gland, if there is no chloride channel, then there is no reabsorption of chloride ions. So this is the general pathophysiology, the whole cycle is here. So what happened when there is no chloride, no water in the sweat gland or in the respiratory or GIT? So there is overall abnormally thickened, dehydrated mucus, and this mucus it gets plugged, it gets colonized with different infectious agent, and it can causes a lot of if it is plugged, it can cause obstruction, inflammation and fibrosis. If it get overgrowth of a particular type of bacteria, then it can cause recurrent type of infection. So what happen is, the manifestation of this is in a European child. The presentation is Y child, because it is an autosomal recessive condition. Cystic fibrosis is one of the listed diseases in the autosomal recessive, which we have previously discussed, and the autosomal recessive cases are present in the childhood age. So in the European dysentery, having a child with this condition, so it's an autosomal recessive type of mutation in present with the child and also adulthood. So in the European child, we have the first manifestation is sinuses and pulmonary recurrent infections. This recurrent infection is in infants and in the children. In children, the main organism is Staph aureus, recurrent Staph aureus infection, and in the adults the main culprit is Pseudomonas aeruginosa, and a new one is Burkholderia specia. So a recurrent infection of these, it leads to chronic obstructive pulmonary disease, in which there is a chronic bronchitis, inflammation, bronchitis, and there is also this bronchitis leads to bronchiectasis, which can be seen on the X-ray. So with this bronchiectasis, we have the digital clubbing. We can also see nasal polyps, and when we do X-ray, we can see reticulo reticulonodular type of pattern on the X-ray. Also we can see this opacification of these polyps. So we have this type of pulmonary type of manifestation, and in the USA the most common cause of mortality in cystic fibrotic patients is pneumonia and bronchiectasis. So this is the pulmonary type of manifestation. The next manifestation, this is a respiratory type of manifestation. The next manifestation is the GIT type, and in the GIT the most common abnormality is in the pancreas. What happened to the pancreas? There is dehydrated thickened mucus plugging in the pancreatic duct, which leads to different manifestation, which for example in the newborns, the plugging of the pancreatic duct can cause meconium ileus, which is obstructive cause of bowel obstruction. Then we have if the pancreatic duct is plugged, then it can cause insufficiency, leads to malabsorption. Then we have the steatorrhea, and in the malabsorption we have the vitamin K specifically, and also fat soluble vitamin D and E deficiency. So if there is a vitamin A deficiency, we can see any kind of squamous epithelial tumor type of thing. So we can see squamous carcinoma type of thing. With vitamin K, then we can see bleeding problem. Vitamin D, then we have seen bone problem, and vitamin E respectively antioxidant type of infection. So this is the vitamin insufficiency, malabsorption, steatorrhea, and also we can see there is pancreatic inflammation. If this cystic fibrotic patient also can manifest as cystic fibrosis mediated diabetes mellitus, because the pancreas is secreting insulin, and this insulin the obstruction lead to inflammation, lead to fibrosis. So if the pancreatic duct is obstruct, it can lead to the inflammation of the pancreatic tissue. When there is a loss of pancreatic tissue, then ultimately there is a kind of diabetes which is going to be complicate later in the life. So cystic fibrosis mediated diabetes mellitus, or there is a biliary tract cirrhosis causing the hepatic disease. And the third type of manifestation is fertility. So we have the fertility issue. In the males, we have the infertility, which is in the 95% of the cases in the males, and in the females, we have the subfertility in the females. Females, why? Because there is a abnormal cervical mucosal plugging, which can cause amenorrhea problem. This is subfertility because the mucus is the cervical os is plugged, so there is no passage of menstrual bleeding from the uterus into the outside uterus to the outside of the vaginal canal. The next, infertility in males, 95% cases. Why? Because of the congenital bilateral absence of vas deferens and vas deferens. But there is a thing, there is spermatogenesis is okay, which is contrary to the primary ciliary dyskinesia, in which there is spermatogenesis problem too. So the fourth one is we have in the sweat, and which we will discuss here. So now how to diagnose this type of patient? We have seen that there is no secretion or no reabsorption of chloride, so we can say that there is increase intracellular chloride levels, intracellular chloride concentration. This chloride, increase in the chloride, can lead to a compensatory compensation, which is actually the overactivation of the ENaC, which is known as the sodium channel electrically. ENaC, it overactivates, it can increase sodium reabsorption, and this sodium reabsorption can cause more negative transepithelial potential difference in the different tissues. So this more negativity of the transepithelium is the important criteria in order to is one of the important criteria in order to diagnose cystic fibrosis. So next step to diagnose is the pilocarpine induced sweat test, in which there is increased chloride levels. Also in the newbie screening, we can detect the increase immunoreactive trypsinogen, which is an enzyme of pancreatic tissue, and this is very much immunoreactive. Next, we can see that there is increased sodium deabsorption, so we can see a contraction alkalosis and hypokalemia, which is very much similar to the patient which are taking the loop diuretics. So contraction alkalosis is why it is happened, because there is two processes happen. In the renal tissue, there is a loss of potassium and hydrogen, which can causes hypokalemia, and contraction alkalosis mean loss of hydrogen, mean there is a increase in the levels of carbonate, so alkalosis. Hypokalemia means loss of sodium. Then we have the contraction, it means that there is increase in the extracellular fluid, increase in the sodium levels. So sodium and water is lost, extracellular fluid, there is a sodium and water loss, so there is a contraction alkalosis. So how to treat this type of patient? So treatment is, first we multifactorially treat via chest physiotherapy, we can give albuterol to increase the airway, to decrease the resistance of airway and increase airway current. Next we can give aerosol DNAs. We can also give Brufen to slow the progression of the disease. We can also give azithromycin as an anti-inflammatory agent. Also we can give inhaled type of hypertonic saline, which can suck out the water, hypertonic saline inhaled. And next we can give, for pancreatic insufficiency, we can give pancreolipase or pancreatic lipase to treat the insufficiency. We can combine two drugs. First one is combine avacaftor, which open chloride channels, with combine with luma or tizacaftor, which act as a chaperone to take the protein from the, to correct these all intracellular trafficking by taking the protein to the cell membrane. So it can act as a chaperone, so to give chaperone to correct misfolding and cellular trafficking. So this is how to treat cystic fibrosis. So it is pretty much effective, and these are for pancreatic insufficiencies, and these three are for pulmonary problems. So this is how cystic fibrosis cause problem. Cystic fibrosis genetics, how this happen. So there are a lot of MCQs, a lot of question arises from this particular type of small type of topic, but it is very much high yield, very much tested. It can, the examiner can test cystic fibrosis fibrotic case with linked to genetics, linked to pathophysiology, linked to pharmacology, linked to microbiology. So it is pretty much high yield topic for USMLE.